Hi, everyone who's just joining. We'll just wait a minute or so to give everyone a chance to enter the webinar room. All right, let's get started. Um, Welcome to the program today. We are focused today on the promise and perils of telehealth. This webinar is part of the Pharmacy Ethics webinar series. My name is Mike DiStefano, and I'm an assistant professor at the CU Skaggs School of Pharmacy and Pharmaceutical Sciences, and I'll be moderating this panel today. And this Pharmacy Ethics webinar series is a collaboration between the CU Center for Bioethics and Humanities and the Skaggs School of Pharmacy and Pharmaceutical Sciences. The series is designed for pharmacy students and faculty, clinicians, preceptors, researchers, and other health professionals. And we hope through the series to explore ethical dilemmas in pharmacy practice, research, and policy, and with attention to how history, law, business, and healthcare intersect in shaping today's challenges. And so today we have three excellent panelists joining us to discuss telehealth and its implications for pharmacy. Professor Claudia Haupt is professor of law and political science at Northeastern University, where she teaches constitutional law in both the School of Law and the College of Social Sciences and Humanities. She's a First Amendment scholar, and her research focuses on the intersection of free speech, health and technology, and has a particular emphasis on professional and online speech. Dr. András Fittler is Dean and Associate Professor at the Faculty of Pharmacy at the University of Pécs in Hungary. His work focuses on the public health and policy implications of digital pharmacy services, including risk assessment in the online drug supply chain, internet pharmacies, and falsified medicinal products. And finally, Dr. Ben Hill is a clinical pharmacy specialist based in Columbus, Ohio, who provides remote clinical services to CU Family Medicine in Colorado. In his current role, he supports four family medicine clinics across the Denver metropolitan area through a fully remote practice model. His clinical services include medication therapy management, drug information and support, pharmacotherapy consultations, and population health management. So thank you everyone for being here with us today. And to start, I'm going to direct a question to Ben. Um, could you start by orienting us to the factors that have contributed to the recent growth of telehealth in pharmacy practice?
Yeah, I'd be happy to. So really, we've seen a huge expansion in telehealth, especially in ambulatory care or primary care settings in the outpatient world around the COVID-19 pandemic. During that time, there was a lot of lockdown going on, risk for infection, things like that. And so with that model, a lot of people weren't coming in office, or if you weren't an essential worker, you had to be remote. So for pharmacists, especially whenever I was doing my practice here at the School of Pharmacy here in Skaggs, we went to a fully remote model with some occasional time in person, but mostly expanding our telehealth-based services in that area of opportunity. A lot of that was phone calls, video visits, those kinds of things. And with that, we also had an expansion of legislation because we realized with being in telehealth, we expanded our services provided to a lot of these underserved patients or patients who were worried about coming in for infection, things like that. And we really had an uptick of that around here. fast forwarding now up to like 6 years later from the COVID-19 pandemic, there's still expansions for the telehealth model that is still occurring because we saw a positive growth with it, with expansion of services for people to see mid-level or pharmacist providers, those kinds of things that we're still advocating and fighting for this using collaborative practice agreements, chronic disease state management based protocols, those kinds of things. So really, COVID-19 sparked a lot of negativity, but in the telehealth world, it was very positive for us.
Hmm. Great, thank you. Um, Now, Claudia, could you describe for us the difference between ordinary telemedicine or telehealth, perhaps as Ben's described it, and the direct to prescription business model that has been growing of late?
Yeah, absolutely. So, the idea of telehealth has been around for, a couple of decades. And as Ben said, it really exploded during the COVID-19 pandemic. But the idea essentially is it's just a regular doctor's visit that can span larger distances, right? You're going to see your doctor and all of the, from a legal perspective, all of the guardrails that apply to a doctor-patient relationship still apply in telehealth. So you need a licensed provider. Now we can talk about what licensing looks like. Usually we didn't think about it that much, right? Is the provider licensed in the same state as the patient? When they're in the same locale, we don't really think about that. So that was a question that came up. But you do need a licensed provider. They're subject to professional discipline. They're subject to malpractice liability if things go wrong. They have to get informed consent. And you might think about expanded informed consent in the telehealth context because there are, more things to consent to just by virtue of it being online or on the phone. There are fiduciary duties that apply to professionals, just like in any other sort of in-person doctor-patient relationship. And so the idea of telehealth really is to just take the features of the existing professional relationship and make it possible for people to span larger distances to see their provider. What's happening now is, there's been this trend of direct to consumer marketing for a long time as well. You turn on the TV and all you see is drug ads that basically end with, uh, ask your doctor if whatever pill is being advertised is right for you. So the idea there is, the pharmaceutical marketers have access to the patient audience, and the patient still is required to go to the prescriber and have the same kind of conversation that I just described with all of those legal guardrails in place. What we've seen more recently is this direct to prescription model that bypasses the go talk to your doctor and see if this pill is right for you, and essentially promises that it will be shipped to you in discrete packaging. And what this does is essentially it leverages the business model or it uses the telehealth setup um, to leverage it for its business model. And that could be a great thing, right, in order to give people access to medication. And it could be a terrible thing if it's not actually built on the same legal infrastructure and the same ethical infrastructure as an ordinary doctor's visit is. The biggest problem right now is that we don't know what those guardrails are. And according to, reporting, um, there may be great variety in what the platforms agree to with the providers and how thorough the telehealth visit actually is. It might be a regular telehealth visit, in which case I don't think that that's more of a problem than any ordinary telemedicine. Um, uh, or it could be you just fill out a form and you have prescription medication shipped to your door, in which case that would be a big problem. So I think that's sort of in a nutshell where we are.
Hmm. Great, thank you very much. And moving on to András. So much of your recent research has focused on online pharmacies. So I'm interested in what separates a legitimate online pharmacy from one that should worry us.
We have been following online pharmacies for about 15 years now. And it's interesting what Claudia just mentioned that way before the COVID pandemic, way before we started talking about telemedicine and telehealth, we're talking about right now, illegal online pharmacies were doing just the same. They just had to fill out the form, discreet packaging, and everything is at your mailbox. So practically the main difference between a legal and illegal pharmacy is that there are no restrictions. It's just a vendor aiming to maximize profit, sell the product, and they don't really care if it's a medicine or just a phone or whatever. So anytime a person sees that there are no restrictions for purchases and the main selling point is price and convenience, these two show up at the same time, then you start to become suspicious. Of course, most developed countries in the world have developed registrations, a verification framework. So the most reliable source of information regarding you should worry or not about a website which sells medicines is just to cross-check through the National Authority Registry. But I assume that most patients either don't want to take the time, just they see the opportunity, it's free. I mean, free shipping, free without any restriction. I can buy it without visiting my doctor. It's convenient, it's discreet, so why not? So the problem with verification systems that consumers either don't care or they don't know these systems exist. And one more thing you just mentioned, Ben mentioned, I think, cross-border or cross-state services. These most countries protect their own pharmacy supply chains by restricting where you can deliver your products to. So even if a legal European pharmacy would start selling medications to US citizens, as it is not approved by the NABP, then we can consider it as, I wouldn't say it's illegal, but legally not okay. And illegal sellers practically deliver anywhere, anytime. So if you see signs of no restriction, then you should be suspicious. I don't know if it answers your question.
Mm-hmm. Yeah, certainly. I mean, so am I correct that, one way we might distinguish these concerning online pharmacies from a direct to prescription model is that in the former case, there's not even a pretense of a prescriber or some sort of medical authority in the loop, right? Whereas there's at least that pretense with direct to prescription, and then the question is how well they are, upholding their professional and ethical obligations. Is this accurate?
If I can start with partly yes. I think many vendors have realized that consumers are looking for safety, so they pretend there's some sort of a medical doctor or healthcare professional in the system. However, as you can never check, you just have to believe that's a real person who's in, or let's say we have purchased medications, typically Viagra, Tramadol, I don't know what else, semaglutide, for example. And if you fill out the form, no matter what you fill, you get the product. So that's why I just want to say that they just pretend they have a doctor in the house, but there is not.
Okay.
And I think just to comment on that, I've seen that a lot in the outpatient setting where a lot of patients are like, I can't afford this medication going through the appropriate channels and avenues. And then when they Google online, they're like, oh, I can get this medication for $20, $30. I just fill out this form, answer a couple questions, and then it appears. I've seen some dangerous interactions happen because of this. A lot of times they don't tell us because they feel embarrassed or they feel like we would be passing judgment, which we never would. We just want to know what are you currently taking and where are you getting it so we can provide education to them on, hey, this might not be the best approach. Even though you're feeling these, you could actually be experiencing something else at the same time. We can never guarantee the safety and quality of the product if we don't know where it's coming from.
Yeah, and to follow up on that, Ben, do you find then that you've had to build, asking about this type of sourcing into your patient interactions pretty consistently?
Yeah, that's a great question. I manage a lot of diabetic patients. So hot topic is definitely GLP-1 agonists. A lot of individuals will ask about that, trying to get it. So whenever the price is too high for them because of copays, deductibles, certain types of insurances, those kinds of things, they do ask, or I will try to stimulate the conversation of, hey, you may read this or hear it from someone else about getting it through these online pharmacies. Here are the risks with doing that. Here are the dangers. But if you do ultimately decide, all I ask is that you just be honest with me and let me know so then I can mark it. I can double check. I'll try and do some research on my end, make sure it's an appropriate vendor, or try and get some of that information. But also knowing like, okay, they're on this medication, it could interact with these things farther down the line or cause some other kind of harm. So I just try to establish open, honest communication with a lot of my patients. And if they are interested, I do try to get ahead of that conversation.
Mhm. And so we've been maybe touching on this question already, but I'm interested in what unmet needs are patients trying to address or solve when they turn to, this full spectrum of options, either, telehealth pharmacy through someone like Ben, or an online pharmacy, be it legal or illegal, or one of these direct to prescription businesses. What's driving patients to these sources?
Well, I mean, one is that we have a very well documented shortage of primary care in the United States, and so just access to healthcare is a problem. And the other problem, the other big factor is just the cost, right? And so between access and cost, I think that there is a real need for for these types of services, but then at the same time, right, in light of the dangers that we've just discussed, um, there's a regulatory disconnect between enabling people to actually obtain the medication that they need and being able to do so safely. And so, I think it's easy to, bash the uh, certainly the illegal vendors, but also the direct to prescription model. But at the same time, right, there is certainly a need for that, and the pharmaceutical industry has latched onto that as a promising business model. And so I think rather than trying to make it go away, right, the from a legal perspective, my primary goal would be, well, if this is a an attractive model for consumers, then we need to just make it as safe as possible. And the telehealth model is available, right? It just has to be applied fully to those direct to prescription, for example, uh, uh, platforms that we see.
I think the other thing too is it gives patients the opportunity to really take their health into their own hands. They're like, okay, here's what I'm feeling. Let me go to this pharmacy right here and see if I can get something pretty quick to help fix this situation. I would say weight loss is a big one right now, especially in the United States, where a lot of them feel like diet and exercise isn't working. They may feel some fatigue from talking to their doctors about that or from insurances where this direct to consumer model. Let's fill out questionnaire. Let's get started on something right away. Or even like Lilly Direct or some of the other places where you can just pay cash to get the medication. No more hoops to jump through. Prices are dropping to make it more affordable for these patients. I use that a lot for these individuals because of the pricing. And I know it comes from a reputable source. They're getting it directly. And then I just try to provide education on what to expect. But it does really have the patient advocating for themselves to have some of their chronic conditions fixed in whatever capacity.
Mhm. Yeah, so that's really interesting. You mentioned, obviously reduced frictions, right? There's some increased convenience. You don't have to maybe go through a primary care visit, a referral to a specialist, right? Then talking to a pharmacist. And so this relates also to, right? It's a way that a patient's able to, you know, be autonomous, right? And take control over their health. But do you, any of you, worry, right, that the value that patients place on convenience and reduced friction could also start to incentivize providers, pharmacists, these various business models to meet that value more and more. And this could have, negative trade-offs in terms of quality of care or something like that.
Yeah, I can speak from like a primary care side. It does like twist our arm a little bit when a patient's like, well, if you don't prescribe this, I'm going to go to this other place and obtain this medication because it's cheaper or for whatever convenience. So for us, we're kind of in this ethical dilemma where it's like, this may not be the most appropriate medication, but I would rather them get this versus going somewhere where it could cause even more harm than what I'm currently prescribing. So it does kind of put a little bit bind on some of these primary care providers of just like, okay, I guess I'm going to do a little bit more of this, even though ethically speaking, I think step A and B should be done before step C. I've seen that a lot in situations. I've had patients ask me about that. It is an awkward conversation. I just try to be an open and honest as to why I don't think that would be the best option right now and why we should try plan A and B. But ultimately, it is the patient's decision in the end whether they want to start something or not, or where they're going to end up going to pick it up. So it can cause that really a lot in the primary care setting.
Hmm.
The other thing is that the business model itself lends itself to breaches of fiduciary duties between the prescriber and the patient, even if we're stipulating that there's a licensed provider actually doing a sort of a full-on telehealth visit. So imagine that they're coming to a platform that has a contract with one specific pharmaceutical company. Um, by virtue of that, they'll be pushed in the direction of prescribing the pharmaceutical that that company offers. So it's less likely that alternatives will be discussed, which, if you actually take the sort of fiduciary duty of putting your patient's interests first seriously, there should not be a financial interest in the back of the provider's mind, right? That I'm employed technically, right? I'm contracting, not employed, but I'm contracting with this platform, and so it is in my best interest to prescribe the medication of that particular vendor. So the business model itself, in that respect, is problematic. It's also less likely that non-pharmaceutical alternatives will be discussed if the doctor is actually working for the platform whose business model is to sell uh, the product.
Hmm.
Can I add one thing that
Yeah.
just came to my mind? I was working in community pharmacies in Hungary. So with Central Europe, some people might not be aware. This is like a 10 million country, so it's relatively small. And we have completely different healthcare. Healthcare is okay, it's nice, but we have different legislations regarding marketing and mainly marketing medications and how pharmacies operate. We don't have big chains, so it's kind of different. But what I've recognized that there are, so maybe what Mike just questioned, that what is it okay, what door it opens, what would happen if professionals would start doing telehealth and people would have the freedom to choose between states, countries, night and day, any provider they would be, who would be willing to give the medication they're looking for. And based on my experience in Hungary, and maybe it applies to US also, patients did the same in the offline system. So if they come to me, ask for medication, I told them that, there's an interaction, or I don't suggest this medication because of your age, or there's some sort of contraindication. They just go out of the pharmacy and they go to the next pharmacy and they give it a try there. And if they don't have an option, then they will go to their neighbors and get the medication. So looping back to Ben, I think patients want to make decisions about their healthcare regardless of what the healthcare system tells them to do.
Hmm. Yeah.
And they
So,
don't really see the value of the pharmacist and the
yeah.
doctor's collaboration in providing the best and safest alternative. They just see the restriction that they can do what AI or the internet told them to do.
Yeah, this is an important point because I think it gets at the cultural moment we are in. I mean, maybe we've always been partially in such a moment, but it seems as of late there's so many health influencers and, alternative experts that have gained voice and prominence, and at the same time, a growing distrust in the traditional experts in the health space. And so it seems there is always another voice, right, out there that can support what the patient thinks is best for them. And that creates, challenges for pharmacists, perhaps. Um, I wanted to ask. this is maybe a question for you, Ben, but anyone can feel free to jump in. But what aspects of pharmacy practice are best suited for telehealth models? And are there some medications or clinical situations where this telehealth first model is just not going to be appropriate?
Yeah, I think that's a great question. As okay, we've talked a lot about negatives of telehealth. What are some of the positives that we have seen? I'm a 99.9% telehealth worker doing a lot of different things for my patients. I think the biggest thing is having access and easeability for patients to be seen, either virtually or via telephone for chronic disease state management that doesn't require visual observation. So things like diabetes management, hypertension management, osteoporosis, dyslipidemia, those kinds of things. I don't technically need to see the patient. I can give them a quick phone call, ask to run through their numbers, or for diabetes patients, a lot of them now have continuous glucose monitors, which have been a huge game changer for us with accessibility, price, those kinds of things, because then I can have the report downloaded on my side of the system, give them a call, and make adjustments to their medications. It's really good for patients who might have difficulty with transportation or issues getting to doctor's visits, relying on family members, unstable transportation, essentially. A lot of them really appreciate a phone call, just knowing that they don't have to leave their house and that they feel like they're getting the best care that they can get with the discussion that's going on. I think another thing too, medication reconciliations. I do a lot of times where I'll talk to someone like, hey, can you just go to your medicine cabinet at home, pull out everything that you have, show me the bottle, let's talk about these, let's get rid of things you're no longer taking, and I'm just going to get an accurate list of what you currently are. This is so much easier than whenever they just dump all the pill bottles in a bag. I've seen someone put it in a sleeping pillowcase before, so and just bring it over, and they're like, actually, I don't really know what I'm taking. I just brought you everything that I have. This way, you can really get into the heart and center of that. I've done a lot of education over the phone for like insulin administration, placement of devices, inhalers, those kinds of things, just because they also feel at home, like with no judgment, just sitting there trying it out. And then I just watch and give them some advice, education. I think on the flip side, what makes it a little bit more difficult is if you really need a physical observation of the individual or the device or medication and say that their camera function isn't working properly, yours isn't, or you just need to manipulate the device in hand. Say like a glucometer isn't working and you really need to tangibly hold it to figure out what is going on. Makes it a little bit more difficult. Usually I have to have them come into the clinic to see one of my colleagues to try and assist with it in that situation. I think the other thing too is a lot of patients just prefer to have the virtual visit and then they'll keep skating by and never come in for a physical examination. Especially during the beginning of the pandemic, I've seen charts where it's been a couple years since they've physically been seen just because everything's been telehealth. That can lead to downstream complications if you don't physically lay eyes on them more than just above the head. You need to do a full body assessment to see, okay, are you having complications from diabetes you might not be recognizing or from other chronic conditions? So I'll kind of check patients' charts and see if they've only had telehealth for a year. I'll really push hard to be like, I can't give you another call until you physically see your provider because you need to have a physical assessment just so I can ensure that we can continue this collaboration together.
Hmm. Yeah, great. Since we're kind of on this topic of, you are a pharmacist, you are doing 99.9% telehealth. How does providing telehealth interact with concerns around pharmacist burnout? Does it help or hurt? Are you able to see many more patients than you would otherwise? Of
Yeah,
course, not in a community setting, but
I
ambulatory
think
care, I believe. Yeah.
Yeah, I think it's an interesting topic. It has pros and cons, just like everything. I think the luxury of working from home is I'm in a quiet environment. I don't have anyone interrupting. I don't have anything popping in or out. Or if I get a message from a provider, but I'm in the middle of something, I just kind of mute it or minimize and continue on with my day. So from that aspect, I can get through a lot more work very quickly, knowing I have less interruptions altogether or less background noise, those kinds of things. I think on the flips, oh, well, also the other benefit is I don't have to drive to work. So I never have to fight an hour worth of traffic here in Denver, Colorado, just to get to a clinic and then leave afterwards, go back. So I can usually start the day a little bit more refreshed and have more positive attitude than if I were sitting in the middle of traffic, just like stressed beyond belief trying to get there. I think on the other side too, because you're not in person or aren't physically seeing anyone, you do get a lot more notifications, you get a lot more pings. And if that kind of gives you a little quick spike of anxiety, it can be a lot and overwhelming in a telehealth fully functional capacity. You have to be really on top of communication. And sometimes if you have a emergency or an acute event and you're trying to reach someone on the other side of a clinic, it can take a little bit longer than just walking to the other room and asking like, hey, can you pop over and see them or can you take care of this? So it can cause some other kind of anxieties just around lack of physical support from it overall. I think lastly, too, in terms of like burnout related to staffing things, I know fully remote people who are burnt out because they just don't have enough staff to support it. Because in the company's mind, if I just have a telehealth worker, this should increase productivity because of less distractions. But in reality, the root cause is we just don't have enough workers. We need to hire someone else or two people to assist with this kind of functionality. So just switching someone from in-person to remote will not increase productivity across the system. It might make them specifically more efficient, but the overall encompassing reaction is if you're understaffed, you just really need to hire more staff.
Hmm. Yeah, thanks. That's very, very nuanced, of course. And burnout is, an important topic on the minds of many pharmacists. So
Mm-hmm.
we'll see how this trend ends up um, impacting that, and a research topic for any researchers who are on the call. Moving back now to the, I think, direct to prescription business model. So this is a question for you, Claudia. Right. How do we think about the implications for pharmacists specifically, professional and ethical obligations within this model?
Yeah, so I think one thing that I really want to emphasize is that the whole model depends on the participation of two sets of professionals, right? This wouldn't work with a prescribing doctor, and this wouldn't work with a dispensing pharmacist. And that also means that the entire sort of universe of legal guardrails governing those professions and their regulatory bodies, right? All of that is still in place. And so we're really operating in a space that could um, sort of live up to its promise if we were to kind of fully implement, professional regulation of those professionals that work in the system. So for pharmacists, right, um, again, right, licensing, discipline, malpractice liability, all of those legal um, kind of, limits still apply. And so it's really, in a sense, a call for I think the licensing boards to exercise more oversight. So on the doctor side, for example, we know that from investigative reporting mostly because the platforms themselves are not super forthcoming on this. We know that there are very few sort of companies where doctors have been able to obtain licenses in as many states as possible. And their business sort of is channeled through those individuals. Now, the question is, what do their contracts with the platforms look like? Are they according to the professional and ethical standards? Same with the pharmacies. We know what their um, liability exclusions look like in relation to the consumers, which is basically both for the doctors and the pharmacists. All liability is tried to, be excluded. So you're on your own as a consumer. And but we don't really know what the contracts between the pharmacists and the platforms look like, and we don't really know what the contracts between the doctors and the platforms look like because the platforms aren't really interested in revealing that. Um, and so those are all sort of regulatory access points where our traditional regime of professional regulation would have a hook to investigate. And sort of from a pharmacist perspective, good pharmacy practice as required by the legal and ethical frameworks, I think would get us a long way in ensuring that we're actually serving the population that's trying to access medications in that way.
Mhm. Hmm. And well, so, so what you're saying is that there's an opportunity here for licensing bodies to actually put a microscope onto these business models more than they have been. Is that a correct
I think that's exactly
summary?
right.
Yeah.
I think that's right.
Okay.
And at least from the doctor and also from the lawyer licensing world, we know that licensing boards tend to spend a lot of time on all kinds of things, but quality of practice is not necessarily at the forefront. Um, and so, a little bit of refocusing of licensing and disciplinary activities um, might be might be, in order to ensure that there's continued oversight of good
Mhm.
medical or pharmaceutical practice happening.
Okay. Yeah, thanks. That's helpful. Um, moving back to the rogue online pharmacies, András. So, I mean, how common, very simple question, I guess, how common are the rogue or illicit online pharmacies relative to legitimate online pharmacies?
Before I proceed, I just wanted to mention that when Ben was talking about burnout as a home working pharmacist or pharmacist working from home, you seem to be really enthusiastic. So I think I would want to give it a try if I have an opportunity later on in my life. By the way, I've seen a lot of pharmacists who were completely burned out offline, so you don't have to stay home to burn out. Regarding illegal online pharmacies and legal ones, it's a typical question, and for I think at least a decade or longer, American. It's a Colorado-based company, Legit Script. Maybe you are familiar with it. That's a private telehealth, telemedicine, online pharmacy, online veterinary verifier working for Google, has documented that about 90 something % of illegal form of online sellers, vendors. I call them vendors because an illegal seller is not a pharmacy, are illegal. But the problem is that there's no official database. So whenever you go to any country, you can track and say, let's say in this country we have 100, then the other country we have 2,000. Interestingly, in the US, regardless of its huge size, there's a very, very few number of websites which are legitimate because you have big chains and you have completely different systems. So we just don't know. And the assumptions was that there's about 100,000 illegal websites on the internet, and it's constant. So if they close down something like in Operation Pangea or Pangea, I don't know how you say it, they closed down, let's say 50,000, and next year they found, if you cut off the head, a new head comes out. And I just wanted to share an interesting observation, which also could be a matter of research. And I think it's interesting that traditionally we track down illegal pharmacies through search engines. And even during the COVID, especially when these miracle drugs came out, promising cures for when there was no cure, according to guidelines for COVID, we were able to find, like, let's say, 60% of the search engine results were illegal sellers or driving people to illegal sellers. And during the past 2 or 3 years, just they seem to disappear. So if you want to find an illegal seller through a traditional Google search, which most people use, you really have to work hard. So I assume, and we were just discussing with colleagues, and maybe it's a good fit in this conversation, that probably with search engines, with some sort of AI support or whatever new algorithm, they can just filter out the bad guys. And very likely these people and these networks, because maybe you heard or you know that many often these websites belong to an affiliate network, a huge affiliate network consisting of 1,000 sites redirecting to the same location or different location. It was enormous business. There was a study published where they just somehow downloaded data about the sales of this huge network, and it was like, I would say, $100 million of sales annually. So this is a huge business, and I assume that sooner or later these companies will find a new way to reach out to customers. And my assumption is that they will disguise themselves as telehealth providers, because that's something that's kind of new, and most likely consumers, authorities are not prepared for. So
Hmm.
to put it simple, there's a big number, but probably it's difficult to find them now, and it's they will come out of the system somewhere, but
Mhm.
most likely not as illegal online pharmacies, but as something else.
Hmm. Very interesting. And, I think you already started to answer this next question earlier on, but I think it would be helpful for the attendees to hear it again. But so how can pharmacists help patients that, they see distinguish between, these legitimate online options and the rogue online options? I think you've mentioned some like verification websites, but maybe given the dynamic nature of this market, that's not always going to capture every possible rogue or online option. Are there other indicators of, other red flags for pharmacies to avoid online?
I think we, I think most consumers know, so we don't have to tell them.
Okay.
They just know that it's not okay, but
Hmm.
they do it regardless. But additional, there are red flags, and there's a lot of literature about it, like huge sales discounts. You don't find a physical location of the seller, so you just don't know if it's a Canadian, American, or a European vendor behind the system. Um, what else? You can buy bulk offers, like they offer like medications in bulk, so you can buy like 360 pills. You can buy like 360 pills of Viagra. I mean, like it can make sense for some people, but most of the cases people don't use that much. So usually these are the indicators of illegal sellers.
I
Mhm.
I think the other thing too, that I've encountered is a lot of times they don't tell you what's in the product, or they just say this is whatever the name is that they're selling, or it's like, oh, this is a new formulation of whatever product it is, but they don't tell you exactly how is it new or different from what is already currently available. Or when you go to their website and you try and search, it just gives you a name, price, and then here's the quantity. Nothing else of like, here's where it's manufactured or what kind of standards. It's just flashy right there with a low cost, a lot of product availability for you right then and there.
Mhm.
I will push the GLP-1 again, the GLP-1 button. There are sellers which sell GLP-1. You just buy a vial and it doesn't say anything else, just GLP-1. We don't know which one. So I
Mhm.
just can relate to what Ben is saying, that um, you cannot trace back who is behind it and what's in it.
Mhm.
And I'm afraid that many consumers just really don't care. They proceed without wanting to know.
Yeah, that's a very interesting observation. So, I mean, what do you think is going on there? Do they simply just trust the source, or is this an indicator of, high risk tolerance? Like they know they might not be getting what they're buying, but they're okay, you know, rolling the dice. They figure it'll be what I ordered some of the time, and that's enough. Do you
I
have
think
any
they more
insight?
so trust the price. They're like, oh, I can get this. They say it's this name. Why would anyone try and adulterate this product that they're trying to get out into the market? I had an example of an individual who they were getting something that was mixed with something else, and it resulted in a toxicity from it. So but they don't know because it was never listed in that until we did some investigation where it said subtly, like, oh, it's a combination of multiple things, but not what exactly they were marketing. But for a lot of patients, they're seeing these influencers on whatever social media platform advocating to get on these kinds of products, that your life is going to be better, that you're going to feel great, and all for $50 a month, you can just do these kinds of things. So why would I go to a doctor's visit if I can get it over here? So they're just kind of putting blinders on themselves to purchase this so that they can feel better and live that kind of lifestyle that they see now portrayed on social media.
Mhm.
So on that front, it's also important to keep in mind that even if you have a licensed professional who's an influencer, right? So there might be a lot of reliance on the fact that these professionals are involved. So, like, why would a pharmacist put their license on the line to sell me a bad drug, right? That's actually something that comes up pretty quickly as an answer why do you trust? Well, because there are professionals involved and we trust them. That problem gets even bigger when you look at professionals who go online and, tell their large followings, you should really take this or that drug. And the problem there is that the law does not distinguish between professionals giving advice to the public and, other people giving advice to the public. So even though you can rely on your professional's advice in the professional client or the doctor-patient relationship, those same guardrails don't exist when they're speaking to sort of the public at large. So the TikTok doctors can give you terrible advice and nobody's going to be able to hold them liable because, First Amendment protections in the US protect their speech as much as anybody else's. So there's really no distinction between, expertise and quackery when you're talking to the public at large. And then that reliance on what a professional might say becomes even more problematic.
Can I add one more thing? That, of course, I'm personally biased toward pharmacists and pharmacy because I'm a pharmacist. But in our culture, and maybe it's similar in the US, people have the perception that medications are safe in general. So if you see a tablet, it's quality. If you see a professional like a doctor, he or she knows what to do. If you see a pharmacist, I can trust them. And maybe that the bad guys take advantage that the system generally perceives health professionals, pharmacists, doctors as legitimate, trustworthy, and also ethical. So, yeah, in Hungary, the pharmacists are generally considered as one of the most ethical individuals in the system, similar to doctors, of course. And pharmacists are ethical. So I think regardless, you mentioned companies are financing or supporting some sort of a platform where the dispensers might be incentivized to support the company who owns the system, or the manufacturer owns the system. But I'm pretty sure if there's a licensed pharmacist working there, his or her ethical standards are in place. So financial incentives will be below the ethical, or I would say most of the cases below the ethical morale. And the bad guys don't have this compass in their system. So ethics, I think, is a very important element. And most countries, I just read an article about it, that Europe is a very heterogeneous regarding regulation of telemedicine, telehealth, telepharmacy, distance sale, and these kind of things. And so even in countries where there's a more rigorous regulation, ethical standards of telemedicine has not been established. So it's not a matter of discussion yet. Maybe that's also a reason.
So I'll shift gears to maybe a more conceptual question, but I think it relates to each of these practices we've been discussing. And then hopefully we can move to some audience questions as well. But I'm interested in whether and how telehealth has any implications for our understanding of the pharmacist-patient relationship. And this is a question for any or all of you, but how do you see it transforming that relationship for better or worse?
I mean, from my perspective, I'm a referral-based system, so a provider will be like, "Hey, here's a trusted pharmacist. Please talk to them about whatever disease state." And I just build a relationship a lot of the times over the phone where we never see each other, and occasionally I'll do a virtual visit with them. But it's one of those where I think it doesn't really muddle that in a primary care standing because they already know this is a reputable individual who is referred by my primary care provider who I trust and that I know will are in it for my best interest for the care overall in that kind of a setting. So I really haven't had any major issues with doing it just from a phone call quickly multiple times versus sitting down with someone in person and having a long conversation. I think they more so trust me because I'm more accommodating to their schedules of their busy lives of what's going on, because it's not like, okay, you can only come at this specific time because I have someone else coming in person. I can shift things around with like telephone calls versus virtual visits, those kinds of things, and they really appreciate it, and we build a nice relationship to work together for the future.
Mhm. Okay, let's turn to some of these audience questions. Thank you for submitting these. So here's a question. Do you think there is an ethical obligation to enable digital telemedicine access for people who may not have it because of where they live? So rural areas. If so, would that obligation be on the provider, the government, or someone else?
Right. I mean, so basically that's the big promise, right? Is that we will be able to reach rural areas, we will be able to expand access. That's sort of the promise. It, you know, we've seen some of those discussions around broadband access, more broadly, sort of beyond the telehealth area, and it's just sort of it's sort of a large infrastructure question, right? Who is responsible for building infrastructure that's not roads and bridges, but that's digital infrastructure. And I think that's an open policy question.
Mhm.
I was just going to comment saying, like, at least for the basics, most easiest type is just a telephone conversation, which a lot of people in rural settings still have landline phones. So you can do provide like some base information, especially if you just need to answer a question or they're having symptoms and you need to do a quick assessment over the phone. That's probably the easiest thing that we can do right now to expand access across pretty much 99% of the United States. That next level tier where it's like virtual visits, having smartphone compatibility, Wi-Fi, those things really do need like an infrastructural help. Just because of whatever kind of remote location, it could be hard to get those kinds of services out there.
Mhm. Yeah. There's another comment here about GLP-1s being prescribed inappropriately to patients who do not meet criteria for right the indicated criteria. So maybe their BMI is not in the overweight or obese range. So is this a practice maybe we see in the online pharmacy or direct prescription marketing space?
Oh, for sure. We see that because a lot of the times, back to what we talked about earlier, a provider will be like, hey, I really don't think you need this medication. You don't meet criteria. Let's work on steps A and B, lifestyle modification, dietary modification. Well, with something else, I'm like, well, I got to know I'm going somewhere else to go get this. Yes, because I know I can get this for this drug. I can afford whatever the copay is going to be. I want to look just like those influencers that I see online every day. So it is a huge thing that's coming up and really putting us in a bind as to what are we going to do about that? And ethically, do we just give it to them or do we let them go over to this side and try and figure it out?
Mhm. Mhm.
Right, and even in the sort of more reputable space of direct prescription, there's a large variety of what those requests look like, right? It could be an actual telehealth visit. It could be just sort of a glorified Google form that you can just adjust your weight until, it goes through to the next step. So there's just and you don't even have to go onto the illegal market, which is in a whole, it sounds like there's a whole other universe out there where it's even easier to get your hands uh, on those
Well, yeah, go ahead, András. Yeah.
I just wanted to mention that probably that's one potential danger of or issue that telehealth has to face, that when you are consulting a patient face to face, you see the whole person. You can see the minor changes, the body language, and then maybe you can more easily understand how well he or she describes the truth. In the online platform, I can say that I'm my BMI is 27, and just prove that I don't have that BMI. So you just have to trust the patient, and you don't have the you cannot trust your gut feelings as if you were meeting the patient in person.
Mm-hmm. We just have a few minutes left, so maybe I have like a closing question here that I'll pose to each of you. You know, feel free to answer this or just give your sort of closing thoughts. But you know, telehealth has probably not reached its full potential, right? So what are some of the biggest opportunities telehealth offers for improving the future of pharmacy practice for both patients and pharmacists? And Ben, you can start.
Yeah, I think telehealth is a huge future, especially in the primary care setting for pharmacists. I think really if we could get provider status at the legislation for Medicare to get better reimbursement from them. Right now, it's in specific states for Medicaid. Luckily, in Colorado, we're privileged to be considered providers and can bill and get reimbursement for our services. Same with trying to get on commercial insurance plans, just because we can then be that middleman for patients and for providers that we can have quick services for them. We can get reimbursement. And then that's a huge thing. Pharmacists are expensive. A lot of these smaller clinics can't afford a full-time pharmacist. But if we were able to get even just like part-time or a little bit of our salary back from billing services, we can really expand and grow this profession through the use of telehealth.
Mhm.
Yeah, I mean, I think sort of taking the underlying ethics and values of the provider-patient relationship and transferring them onto this model is going to take a little bit more work. But I think it's a really good investment for all of the benefits that Ben just mentioned. So I think that, there's some regulatory, possibly, technical details that need to be ironed out, but I think in the end, in the interest of patient access and patient safety, it's well worth the effort to actually, make sure that we have a safe, a safe system in place.
It was inspiring to take part in this conversation, and pharmacists in my environment are relatively conservative. So telemedicine and telepharmacy is not really an accepted practice in Central Europe yet. And I'm a bit sad about it because we could reach out to those patients whom we would not be able to identify, who just don't want to take the time. Maybe they don't have to be disabled or live in a remote area. They just don't want to go into the pharmacy. And if we would have a lot of people like Ben around here who can prove that you can just do this, it works, then more and more pharmacists would be open to this, and sooner or later more and more patients would just give it a try, and they would say, yeah, it's cool, why not? And I think it's more cost effective. So, and if you have your brains and hearts in a good place, no matter if you work online or offline, probably the result will be the same. Oh?
Mhm. Well, thank you, Ben, András, Claudia, for joining us. Uh, those of you who have joined, we thank you very much. Please be on the lookout for the resumption of this series in the fall, next semester. Also, you will receive a short survey through email. Please fill that out. It helps us make sure that we're keeping this series relevant for all of you. And a recording will be posted for those of you who are interested as well. Thank you and have a good rest of your day.
Thank you all.
Thank
Goodbye.
you.